Okay, good morning, everybody, and welcome to our talk today. Our presenter today is Dr. Darren Joseph. He's an adult pulmonologist and specialist physician. He completed his undergraduate training at the University of Cape Town and later his specialist and subspecialist training at the University of Pretoria. Since completing his specializations, Dr. Joseph has held joint appointments as a specialist consultant physician in the Department of Internal Medicine at Steve Biko Hospital, as well as senior lecturer in the Faculty of Health Sciences, University of Pretoria. He co-manages a general medical unit and works in the adult pulmonology and medical critical care units. He is extensively involved in student, registrar, and fellow training and has several publications in the field of general medicine and pulmonology. He also works as a private pulmonologist at Mediclinic Midstream Hospital. Thank you very much.
Thank you. So one of the tricks I've learned now over the years is if you want to sound clever, you choose a topic that no one knows anything about. And automatically you sound like you're very knowledgeable about something, but this is actually going to be fairly a superficial discussion about something that's quite rare. I call it PAP syndrome or PUP syndrome because it's giving it a local flavor, but also the real name doesn't actually fit on the screen. So you'll see here it's pulmonary alveolar, and some people add the phospholipoproteinosis syndrome. So it's got a very long name, and it's quite a rare syndrome, but the reason why I'm talking about it, first of all, it's got a nice overlap between clinical medicine and pathology. That's nice for this discussion. But also, it is a rare entity, but the differentials for this syndrome are very common. So people will more easily diagnose the differential and miss this. And for that reason, it's often a very delayed diagnosis, as you'll see. So it's a diffuse lung disease. It's rare, and it's essentially a problem to do with surfactant clearance. So for some or other reason, your body naturally produces surfactant, but it has to recycle it and clear it. And this disease doesn't allow your body to do that effectively. So the lungs essentially fill up with this fluid. So it's a non-inflammatory disease. And because of that, the lung architecture is preserved. And so that means it's a treatable disease, and you can have complete resolution and you can go back to normal, healthy lungs at least for a while. So some people, it is life-threatening. It can lead to respiratory failure and death, but at least complete remission in some cases is also achievable. So surfactant, we all remember, is an oily substance. It's present in the lung at the air-liquid tissue interface. It's a very thin layer, so it doesn't really interfere with gas exchange and the function of the lung. But it serves a lot of purposes. So it's composed of phospholipids, cholesterols, and proteins. And it's those proteins that are quite important for the function of surfactants. So some of them are part of the innate immune response in the lung. So that's the SP, A, and D. And then others are these hydrophobic phosphoproteins, and they basically reduce the surface tension of the lung and stabilize the alveoli. So what that really means is, if you can imagine a lung without surfactants on the left, you've got alveoli of different sizes. And so the smaller the radius, the higher the pressure in that alveolus. So what will tend to happen is that alveolus would want to empty and push air essentially into alveoli that have lower pressure. And so if you breathe in, the air is going to preferentially go into alveoli with low pressure, and the smaller ones would tend to collapse. So what surfactant does is it lowers the surface tension in the alveolus to kind of equalize the pressure regardless of size. So that the closer those molecules are together, the greater their action is in reducing surface tension. So as the alveolus gets bigger, the surface tension equalizes with the alveoli that are smaller. So the air can kind of flow through the lungs. So it serves a real vital role in lung health. But there is a life cycle. So remember, you've got two alveolar epithelial cells, the type 1 and type 2. And the type 2 alveolar epithelial cells are the cells that secrete this stuff. And once it's secreted into the airway, it forms that layer. So you can see there's that green sort of monolayer on top of the alveolar epithelium. And that layer gradually gives off bits of these surfactant molecules, which then have to get taken up by cells. So in roughly equal proportions, it gets taken back up by the alveolar 2 cells, which can then recycle it and resecrete it. But another cell that's really important in the catabolism of the surfactant is the macrophage, the alveolar macrophage. And the alveolar macrophage does that under the action of a cytokine called GM-CSF. And that is the major cytokine that's gone wrong when you have this disease. So it's a critical regulator of surfactant homeostasis. It's granulite macrophage colony stimulating factors, its full name. It's released by the epithelium itself, but also other cells in the body. And essentially it binds on receptors on the macrophage, then acts via a secondary messenger system to have effects on the macrophage itself. But the main effect that we're talking about is the surfactant metabolism or catabolism that it does. So unfortunately, it's always mice that have to suffer the fate of humans. But they found that if they knocked out the GM-CSF from mice, then they were able to replicate the disease, the PAP disease, in those mice. And that's how they realized only quite recently that this is the critical cytokine for the pathogenesis of this disease. So we can classify PAP into different groups. So essentially the major group that we talk about is the disruption of either GM-CSF signaling itself or the effects of GM-CSF, the sort of downstream pathways. And all of these things, the disease is due to reduced surfactant clearance. So by far, the majority of patients have an autoimmune form of this disease. They've got a neutralizing anti-GM-CSF antibody, and that's about 90% of all of this. There is a group called hereditary PAP, which has got to do with the receptor for the antibody, well, the receptor for the cytokine at least. There's the genes that are involved. And so obviously, if it's a genetic form of disease, it tends to manifest earlier in children usually. And then there's a very important group that we call secondary PAP. And so here, the cytokine itself is okay, but the macrophage is the problem. And so in people who've got either inherited or acquired macrophage dysfunctions or deficiencies, which makes up about 10% or just under 10% of the remainder of cases, this can actually also result in a similar effect. Now, the significance of this is that the secondary diseases themselves have got a high mortality associated with them that you'll see. So this group doesn't tend to do as well, generally speaking, in long-term mortality because of the associated disease. And so it becomes quite important to diagnose this, because then if you treat the secondary cause, it doesn't matter what happens with the PAP really. There is unfortunately a group that's unclassified, so you can't really find the associated cause. It doesn't seem to be an antibody problem. It doesn't seem to be a receptor problem. You can't find a secondary problem. So we call it unclassified. And there was a group previously called idiopathic PAP, which isn't the same as unclassified PAP. It used to refer to autoimmune PAP. But now that we know that we have these autoantibodies, the terminology's changed. So it becomes a little bit confusing. And then to make it more confusing, there are other disorders of surfactant production, which is not really PAP at all, but they used to call this congenital PAP, because there is a surfactant clearance component to this, but it's essentially genetic diseases where you produce abnormal surfactant to begin with. And so they've now replaced the congenital PAP term with this pulmonary surfactant metabolic dysfunction disorder term. Again, this is something that the pediatric pulmonologists see, because it usually presents in neonates and in early childhood, occasionally later, but usually quite early on. So that's the classification. So secondary PAP is the important one for us as clinicians, besides having to recognize PAP as an entity, because you can see there's a lot of secondary exposures and systemic diseases that are related. So what they all have in common is that they all have either a macrophage deficiency or a macrophage dysfunction problem. And I think that they speak for themselves. So HIV and hematologic malignancies and things like that. These are common entities. And unfortunately, when they get macrophage dysfunction, they are predisposed to more significant diseases like PAP. But okay. So the exposures are quite interesting because this is something that we often see. We have patients that are very commonly exposed to these things. And people know, I'm just going to talk about silica, but people obviously know about silicosis. But what's less known is this thing called silicoproteinosis, which is also called accelerated silicosis. And it's basically a very accelerated form of silicosis with a lot of features of PAP, because if you didn't know, silica is actually very toxic to the macrophage. That's why there's often a TB associated with patients with silicosis. So there's the silicotuberculosis entity. So in people that are exposed to extremely high concentrations of silica dusts, for example, sandblasters, they don't use the appropriate protection, they get this overwhelming amount of exposure and toxic exposure, which is then toxic to the macrophage. And it can be so overwhelming that you can actually get a form of alveolar proteinosis on top of their silicosis. So it is a recognized entity. Fortunately, with protective mechanisms, we don't see it that often anymore. So it is a rare condition. There's only really US and Japanese data, but that seems to be about the prevalence, about 0.3 to 7 per million population. So as I said, it is in itself not a very important disease, and most people won't ever see one of these diseases. But it is an important differential for diseases that are very common that can look virtually identical. So it is good to have it in the back of your mind, particularly if you're treating patients for something like cardiac failure and they're not getting better, you should think about this. So the typical age of presentation is about 40 to 50 years, but it can affect any age. So from neonates with some of these hereditary diseases right the way through to later life. So you can always consider it in any patient. There's a male bias, but they suspect it's because there's a smoking association with the disease. They suspect that the smoking patterns have something to do with that male bias, and it's not really a gender difference there. So how does it look? So for the clinicians, it's important to remember this disease. It's a very insidious disease. Usually patients have symptoms that progress over weeks or months. The average is about 9 months, 7 to 9 months. It's quite interesting that people can have really terrible x-rays that can actually be fairly asymptomatic and have fairly normal clinical exams despite those x-rays. But the main symptom is this progressive shortness of breath. And then sometimes people have cough and just general fatigue is common. Fever and sputum production is a bit more uncommon. And so if you have that, you should suspect a secondary infection. And it's usual that people have gone through trials of treatment for other things for months before it's diagnosed. The clinical exam is misleading. You can sometimes hear crackles, but they're usually quite soft. And clubbing and cyanosis is not really a feature of the disease. So it's fairly rare that you get that. So you can see that would be a typical X-ray for someone with alveolar proteinosis. You get these diffuse bilateral alveolar opacities, usually in a perihilar predominance. So it looks very typical, like a pulmonary edema usually. So the clue really is that, like you can see in this X-ray, they often have a normal heart size, and they don't have the other clinical and radiological features that you would expect with someone who's got cardiac failure. So it's almost like a non-cardiogenic pulmonary edema picture. Occasionally, the peripheral lung is spared, so you can see almost like a black line around the lung and around the heart border where there's some sparing. But any pattern really can exist. So it can be asymmetric, it can be unilateral even, focal, and then sometimes it looks nodular and mixed alveolar interstitial. So no pattern really is diagnostic or excludes the disease. So this is a patient that we had at Steve Biko fairly recently. This was her X-ray. So she was a 32-year-old woman who was HIV negative, and she was pregnant at the time that this X-ray was taken, actually presenting in her third trimester, quite late, with persistent dyspnea, cough, and hypoxemia. So obviously there was this assumption about cardiac component to her disease, and that was ruled out, and eventually found her way to the pulmonology department. And this lady ended up having alveolar proteinosis. So we'll come back to her stuff just now. But as you know, that X-ray has a huge differential diagnosis. And I just brainstormed some diseases that can look like that. So there's plenty more. And you'll see PAP is right at the bottom, but it is nevertheless on the list. So these things are all more common than alveolar proteinosis, but don't forget that alveolar proteinosis is on that list. The high-resolution CT has also got some nice signs. So you get this so-called geographic appearance, where you have these discrete, sort of angulated and straight-margined areas of involvement that border areas that look relatively normal. And then you also have, so these are alveolar opacities, but you also have superimposed interlobular septal thickening, which is from surfactant that's kind of been pushed to the periphery of the secondary pulmonary lobule. And so you get this appearance that they call crazy paving, which is paving that looks like that. So there you can see this typical geographic appearance where you get these discrete areas of involvement next to areas that are relatively spared. And then on the right, you can see the scan that's got that typical crazy paving appearance where you've got alveolar opacities, and then it's the superimposed linear interalveolar septal thickening on top of that. That gives you that crazy paving look. And that's quite typical for PAP, but again, it's not unique to PAP. Here are just some more examples. The scan on the right, you can see how you sometimes get that peripheral area of sparing. You get that sort of rim of normal tissue at the periphery of the lung, and that can kind of outline it. So this was our patient, the one that came to Steve Biko Hospital, very classical X-ray for PAP, unfortunately also for a lot of other diseases as well. So there is a long list of differentials. All of these things, again, can cause crazy paving appearance. It's not unique to alveolar proteinosis, but it is classically described with it. Lab studies, now unfortunately, we don't have a lot in our laboratories in South Africa that we can use for this disease. You can see that most routine studies are normal. It is important to look for secondary associations, like we mentioned. So there'll be specific studies for those. And you must also rule out the differential diagnosis. So it's, you could do things like BMP to look for cardiac failure, etc. LDH, interestingly, is often elevated in these patients, but it's not specific. So the gold standard is obviously a GM-CSF autoantibody, but as far as I know, I've tried phoning around. This doesn't seem to be available here. But it is a test that supposedly has a sensitivity and specificity of 100% for autoimmune PAP. So I don't know any test that's got a sensitivity and specificity like that, really. So it is quite a useful test if you can do it. And they say that the levels that are done on the lavage fluid is slightly better than that done on serum, but serum is usually where we test this. So there are other biomarkers that are available in some settings, but they're not as sensitive or specific. So these also elevate in the disease, but the interpretation is difficult. So there's lots of these biomarkers. And then obviously for the hereditary diseases, you'd like to do genetics if you have it available. This was our patient at Steve Biko. You can see really bland, benign bloods, but an LDH that was 828. So again, fits the description very well. Lung function tests also not very exciting. The main thing here is that the diffusion is often quite reduced, very out of proportion to the rest of the lung function. So you can have restriction a little bit, but usually it's the diffusion that's the giveaway that there's a problem. And so on the gas itself, you can have hypoxic respiratory failure with a high gradient and reduced CO2 as a result of this abnormality. So the interesting part for us is that at bronchoscopy, there's very typical features that help us make the diagnosis. So usually in these patients, we're doing the bronch usually to exclude other problems, other infections and things. But there is a characteristic alveolar material that gives the diagnosis away usually. And so it's described as opaque or milky or waxy. You can see on image B how it kind of looks. That's after it's sat for a while and the sediment has fallen down. And then if you send it for microscopy, there's also very typical features. So you get these foamy macrophages, which are macrophages filled with lipid inclusions. And then you also get, because of the amount of surfactant that's there, if you stain it with periodic acid Schiff staining, it stains pink, and you see this abundance of granular lipoproteinaceous material all over on the sample, and that's basically surfactant and surfactant that's included in other cells as being stain positive with that stain. So it is helpful to rule out infection, and the giveaway there would be a high neutrophil count, but essentially it's also somewhat diagnostic for this disease. So this was our patient, that was her sample that went for bronchoalveolar lavage. Initially, that's how her sample looked, which is very typical for patients with alveolar proteinosis. And that's why, another reason why we call this PAP syndrome. Okay. So the biopsy, so it's interesting, because it's patchy, you get that geographic appearance. Particularly if you do transbronchial samples, you can miss the disease, because you can just biopsy an area of normal lung, and then you might not see, it might not be a truly representative sample. So you do need to keep that in mind. And the other thing to remember is that you can diagnose the disease, but you can't diagnose the cause. So you can prove the patient has alveolar proteinosis, but why they've got it, that you can't tell on biopsy. But you typically see an image like that on the right where you have preserved architecture. So it looks like a normal alveolar system and alveolar structure, but it's full of this pink amorphous material that's PAS positive. And that's all the surfactant that hasn't been cleared. So to diagnose it, you need to suspect it, which requires a high index of suspicion. You must exclude the other differentials. If you can do the testing, you can confirm the diagnosis with antibody testing, and usually that's then diagnosis made. In our setting, unfortunately, we often have to go further and prove the alveolar proteinosis on bronchoscopy and with biopsy. And then once you've got the diagnosis, you should rule out the secondary cause. And only then, if you can't find one, can you assume it's primary PAP, which is what we had to do in our case, unfortunately. So as I said, the time to diagnosis is about 9 months. Some studies, it's even longer. Because people present progressively, they're relatively asymptomatic and often have milder symptoms. It's a long process before they're diagnosed. And then unfortunately, some people do get rapidly progressive disease. Then what's interesting is that in a very small percentage, but a significant amount of patients, there is this stabilization or spontaneous remission, which can also occur. So the significance of that is that you don't necessarily have to treat every single patient. So if you've got mild disease, you can watch them closely and see if they spontaneously remit. The majority, unfortunately, will progress. And so you'll see that the 5-year survival without therapy is about 85%, but it is pretty good if you treat the patients. And obviously, secondary PAP has got a much worse prognosis because of all the terrible disease associations that it has with it, like hematological malignancy, other cancers. So the management, therefore, is dependent on the severity of disease. So again, there's no real consensus for when you would intervene, but generally, the sicker you are, the more likely you are to do something. Supportive care, it's the same really for all lung diseases, vaccination, smoking cessation, and supplemental oxygen. It kind of goes without saying. But the mainstay of therapy really is this whole lung lavage, which I don't know if you've seen or heard this, but whole lung lavage is essentially you washing out the lung. So it's like doing a bronchoalveolar lavage, but on like an industrial scale. So it's under general anesthetic. You have to do isolated lung ventilation. So we usually use a double lumen ET tube so that we can ventilate one lung and then do the procedure on the other. So usually the patient's lying on their side. The ventilated lung is underneath at the bottom, and the lung you're washing is on top because now you want gravity to help you to get all the fluid out again. So the patient has to be able to tolerate a procedure like that in order to do it. And then you instill massive amounts of saline into the lung. So you can use up to 50 liters per lung sometimes to wash this out. So the average is around 20 or 25 liters or so. And you're installing massive amounts of fluid, and then you're removing all of the effluent. And some people will do physio while the fluid's in to try and get as much of the stuff up as possible. And then in some cases, and you'll see in our case, you have to use ECMO because they can't tolerate single lung ventilation. So you've got to support them with other means in order to be able to do the procedure. So this was our patient in theatre. So you can see the fluid is in, and that's the physiotherapist there with the vibrating tool to try and almost do chest physio and anesthesia to try and loosen up all the secretions. That's some of the lavage fluid that came out. You can see the massive amounts of saline that get used in this procedure. And basically, you know when to terminate the procedure by the clearing of the fluid. So it starts off very milky, very turbid, and then you can see the one on the right, finally there's clearing, you've got it all out. So then you know that the procedure on that lung is now ended, and you can either then go to the next lung, or you can do the procedure sequentially on another date. So it is safe, it's effective, and the problem is it only treats the sort of downstream effect of the problem, which is the surfactant that's built up in the lung. It doesn't treat the cause. But for some people, and more often than not, once you've done this, a lot of people go into remission just by having lavaged the lung. So they can remain disease-free for quite some time before you might have to go in and repeat the process again. There are some complications that are some of them fairly interesting. So, you know, they can get hypoxic, and obviously pneumonia and sepsis is common. hydropneumothorax from the procedure, and pneumomediastinum. These are complications of the procedure, but generally speaking, it's a safe procedure as long as you're careful with how you do it. And you can see the majority achieves disease stability lasting quite a while. So the mortality therefore improves quite significantly if you offer this procedure to patients. That was our patient. So you can see the ECMO line on the right, but her sort of pre-operative, pre-procedural X-ray compared to what happened afterwards, you can see there's a significant improvement in how the lungs look. So we were quite happy with that result. Unfortunately, life's not always kind, and this poor patient ended up demising from an intracranial hemorrhage, which we think was from the ECMO. So she actually did very well from a respiratory point of view, but unfortunately the associated complications are significant, and she ended up passing away a few weeks after the procedure. So if you can't do this, although it's the mainstay of treatment, there are some experimental therapies now, pharmacological approaches. So recombinant human GM-CSF therapy is an interesting one. So you're replacing the cytokine that's not working in your patient. It is available as a subcutaneous or an inhaled form. And I think inhaled is probably more effective. Very few, if any, which is also interesting, safety concerns have been identified. But we're still not sure when it should be used, how much you need to give, how often you need to give it. All of that is still to be determined. So it's off-label in these patients. Because it's a non-inflammatory disease, there's no role for steroids and immunosuppressants. And in fact, it might increase mortality. So we don't give that at all. But rituximab may be useful because you're now inhibiting the cells that produce these autoantibodies. So there might be a role there. And the same with plasma exchange is that you can try to get rid of these autoantibodies that are being circulated. And then interesting, just statins, simple statins might have a role to play as well because of the way that they affect macrophage cholesterol metabolism. So they might also be useful. And then unfortunately, if nothing else works and the lung is now completely end stage, you might have to offer these patients transplants. So there are case reports of transplants in these patients. So that's alveolar proteinosis. So it is a rare syndrome. And the main reason to mention it is that it is a treatable disease for very common diseases, as a differential for very common diseases that we see all the time. So you should think about it really in everybody, men, women, all ages, all ethnicities. It's due to surfactant clearance, usually related to GM-CSF as a problem. But the most important thing for us as clinicians is really these secondary associations. So if you get these patients, which is unlikely, unfortunately, the main thing to remember is rule out the secondary causes, because there you can really make a difference in terms of their long-term outcome. And the whole lung lavage it's relatively easy to do. We have it everywhere, even in the state sector. So, it is a treatable disease even in our setting. And that's it. Thanks.
Thank you, Darren. Dr. Franco, welcome. I think he's the director at AMPAT, I think, in Upper Laboratories. Yeah, just what I want to say, Darren is actually a partner in the practice, and this was really a beautiful presentation. I think for the student, the something for the take-home message is that whatever you say as opacity in the X-ray should actually ring a bell, not only about pneumonia. You have to think in the term of what could be feeling, because opacity in the radiological that most people see means there's something filling the alveolar spaces. Could be water, could be cell, could be fast, or could be cancer cell, or could be cell, eosinophil and something like that. So you have to think broadly. And the problem that the presentation on the radiological aspect of it is look like pulmonary edema, or sometimes look just like pneumonia or lipidic carcinoma or something like that. So if the patient not seen by pulmonologist, unfortunately, that it get missed completely. Nobody can see it. So it's like I always say, no substitution for thinking broadly. You have to think broadly about the diagnosis. And I think in this case, of course, unfortunate that the patient really need to have ECMO. In most cases, you could actually do the lavage a bit more earlier. If you diagnose earlier, they didn't go into ARDS. I don't know why, where they already went to ARDS, but you could actually do one lung and move to other lung. Okay, but if you pick up earlier and diagnosis is coming quite earlier there. So in terms of the therapy, I think there's some therapy. I know in Japanese population, there's quite a bit of trial about actually the fact that it works. But in South Africa, of course, in a context that is very expensive, we can't actually able to afford the treatment as such. And that's where a problem comes in. But yes, it's difficult to diagnose. It's a difficult diagnosis. That's why I went to University of Pretoria. We thought that we know everything. But the truth that you need to have a level of transfer of this patient and get an opinion as urgent as possible, especially for our registrars, our fellows. Please get an opinion, and I think probably you can get an expertise who could diagnose. And I think that's for me, it's a beautiful case, Darren. Thank you. In terms of the labs part here, do you guys have the capacity? Because I know you guys been on immunology at I think quite a stronger providing immunology in South Africa as a lab. I want to know, do you guys do the GMS?
But we don't do the autoantibody. I'll now take a picture. I'm going to ask if we can maybe implement the test.
Okay, and part care?
No, not as far as I know. But
Yeah.
we can.
Yeah, but these are the things that actually I think ideally South Africa we should be doing, because we've got 64 million people in this country with a lot of medical conditions. So we actually need, I think our labs actually need to kind of reach the same cutting edge like the any other labs across the globe, so that we can be able to get early diagnosis. How do you manage to reach your diagnosis based on the biopsy only?
Yeah, this patient had a surgical lung biopsy, which proved that, but then we excluded secondary causes of finding.
Question. You said it's due to GM-CSF impaired signaling, which uses the JAK-STAT pathway. Is there overexpression or underexpression of the JAK-STAT pathway?
No, it becomes underexpressed. Yeah,
Okay.
yeah.
So I was just wondering,
Okay,
because I was wondering about the role of a JAK2 inhibitor, for example.
Yeah, no, it's just that's just the messenger system that uses it,
Okay.
but they essentially neutralize that antibody, make it ineffective.
Was there something then related to a pregnancy or not? What happened to the pregnancy?
So the pregnancy she delivered, so that was successful, and unfortunately the symptoms persisted after that, and so all of this intervention happened after the successful delivery. So the child's, as far as we know, is still alive.
So obviously we know that there's complications with ECMO. So do you think it's better to do lavage more regularly and less invasive for aggressive,
Yeah.
probably for a future? Or do it massively once and see.
If you did one lung, for example, instead of doing both lungs, you did it less vigorously, whatever, you would still require the ECMO, because she couldn't tolerate a single lung ventilation. That was the issue. So the procedure wasn't complicated like the ECMO. The ECMO is necessary to do any intervention. Unfortunately, without an intervention, there was no way we could treat her. So you were stuck there.
Yes. Did she deliver before the procedure?
Yeah, she was postpartum by a few months before we did it.
But very interesting that I think I recently were in Europe at Groningen University, and where they have patient actually on ECMO about 6 weeks, 2 months and everything. And they make it like a walk in the park. Absolutely, like, they don't have really issue with infections, they don't have issue with a lot of stuff and everything. So I don't know why. I think in our context, perhaps maybe, it's just a matter of
But they probably have dedicated teams doing only that all the time.
and
Yeah, we're lacking that. We don't.
It's experience.
It's very much
that's
the
in the details.
logistics and the details and the people involved and the people doing it.
I think that's where we need to go towards, because ECMO is not one-man game. And I remember in that ICU, they have over 33 specialists that are actually dealing with the same. Obviously, with the same, the obvious effort is to make sure that it's a better outcome. And I think something that I think we need to reconsider in our practices, obviously, because an ECMO for me, it's really very good. It's got a role in it. But I think, again, if it's not utilized properly, it becomes a tool of mortality. Yeah, and I think this is quite a young patient, actually. And yeah, the question that, yes, you do no harm, but unfortunately that you have no control over it. You save the lungs, or so it's quite a very difficult moment. But I think, yeah. So genetically, we think it's genetically hereditary. We thought.
Yeah, we're thinking her because we couldn't test genetics, but the odds are it was an autoimmune process. But
I think I remember it was not transmittance of autosomal dominant, because it means you can't actually give to the family. I think
I don't know, honestly.
But they should have symptoms before the pregnancy.
During it developed
So
during the
it's
pregnancy.
autoimmune during pregnancy
Yeah.
that developed.
So I don't think the pregnancy precipitated anything. I think that it possibly masked. So people started going down the whole, what has the
Maybe
pregnancy done?
rather unmasked.
Yeah.
because they tend to become much more sicker. But as I say, if the patient didn't reach pulmonology, the first thing is going to be pulmonary edema, will be pneumonia. You'll send the first check went through number of medication, antibiotics to treat pulmonary edema, pro-BNP, all these tests looking
So
for
she had
something.
gone through cardiology and the physician.
Exactly.
And then I remember they put up the scan in our X-ray meeting, and then we looked at it. We thought, oh, hang on, this could be, something else. And then we got surgeons involved and proved it on biopsy and then lavage.
But also
I don't think
COVID
the
happens
pregnancy
like that
masked
too.
it.
COVID,
Yeah, they
so
can.
just-
Yeah,
It's exactly.
That's right. Yeah.
And I've covered like it, you can have something pneumonia like that. So the questions about actually getting those patients to pulmonology ASPA as soon as possible.
Non-resolving
Yeah. Pneumonia.
treat
But
what's common, and if it's not resolving,
yeah, but I mean, I think again,
It's also exclusion. I mean, CRP was normal, white cell count was normal.
I think
So,
that's where
so you would see it initially, and then you would exclude the common causes.
I think it's
That
very
is
important.
something
That's why I think you have to look at your CRP, pro-BNP, and PCT and FangiTel. And if those are negative, then get a pulmonology opinion. Steve Biko, because have pulmonology, midstream pulmonology, there are a lot of hospital with pulmonologists, and then you got to get opinion. And then you can actually improve the diagnostic time, because ideally you should read diagnosis very quicker than actually. And actually you could do a diagnosis just by even doing lavage without doing lung biopsy.
Yeah.
You could actually do that. So there are quite a lot of things. I think in the college, it's a big exams whether this patient actually to go to biopsy, because you're thinking about the complication post biopsy if there's special respiratory compromise. But that's a beautiful one, Darren.
So those patients don't have a cold. They don't have a productive cold.
usually much later.
Drier, but
They're tired and a bit dyspneic. That's usually all.
But also, I think the reason behind that is because the sputum is very thick and gelatinous. So they are not like, like you could cough, and the body is unable to prepare it to it. Remember, for you to cough, you need those, the sputum must move from alveolar to the larger airway where there's a lot of good receptors, the mucin 5. Then from there you cough it out. But in that case,
It's not an irritating type of
because it's alveolar.
gland, so it doesn't stimulate the cough receptor.
But actually, alveolar doesn't even have a great cough receptor.
No, it doesn't. But when it fills, because it's so benign.
Always nice to listen to the clinicians, because I mean it's something we never hear. So what I can say is it's a very, very important disease for the college exam. Our histopathologist, because they're very characteristic kind of look. If you haven't seen it, you probably won't pick it up, and you'll think it's nemesis. Yeah, I guess it's got the differences though is that this is more granular. Nemesis is a little bit more bubbly, and you can actually see little cysts. Nemesis got a little bit more inflammation, but it opens up a whole lot of differential diagnoses, because sometimes you see some granulomas in here. Obviously, in some of the chronic infections, you can see lots of granulomas. But I think if you put the clinical thing and the pathology together, but it's not that easy, because it can be very patchy within the lung. But if you see, like, there is a bit of the histopathological differential diagnosis as well, even cryptococcus.
Could be anything.
Anything with a bit of an accident.
Those foamy macrophages, why do they get that?
Look, I think it's probably some of the healthy macrophages trying to mop up all the lipid-like materials in there, because there's obviously the cholesterol component. Interestingly as well, you can see cholesterol crystals as well within that thing. So the cholesterol is actually part of it. I found a comment about the statins quite interesting.
Yeah.
That might help. Anyways, it's very important for the exams. If you haven't seen it, you probably won't pick it up in the exam. There's always one.
That's one of those things you always think is just for the exams.
Yeah,
not
yeah,
for
yeah.
real life.
Until you see
one.
Until you see your one in a lifetime.
Yeah.
That's
But the view is always say, it's not about what you know. The biggest fear should be about what you don't know. And I think that we should put forward a mindset into what we don't know. And we should be reaching into those areas we don't know, because I think this is what's been missed and this is what most of our patients think. But this side, I think, again, we need to kind of just be very vigilant about it. No substitute for thinking. Please think. It's important. Thank you. And this is the reason why we really do most of these presentations, is to make sure that you don't get bogged up with the daily routine stuff, and then out of blue, most of these patients come in and missing them. So the idea is that we really do presentation for this caliber to make sure that because once we educate everybody out there, make sure that they have knowledge, they have skills, and we always think that the laboratory medicine, I mean, as we say, pathologists are people that hiding in the dark places, in the basement of the building, on the corners, and nobody really gets to hear their voices. And I think for us, I think this platform gives us that, for them to share their skills when they sit in the labs, the always what they see. And I would like to feel what Michelle or Karabu does there with my UKE. They need to tell me what the challenges that they face and everything. And that's why we have this one as a presentation, for that reason. And I think it's really, for me, I've learned quite a lot and been quite inspirational. And I think we're quite grateful for Patke, Ampat, for you guys, your staff, to join us and celebrate. And I think we definitely appreciate it. Yeah. And I think we've done quite a lot of presentation now. It's available as podcasts. So it goes in the podcast and everybody can access the student, the fellows and everything, because we believe that if a doctor mismanages patient out there, we as a pulmonologist, we must take responsibility, because we failed to create a platform for education. Hence, we're taking our responsibility and make sure that we educate everybody out there. And if they don't read the podcast, if they refuse to get educated, then that's beyond us. But we do our best. Yeah, and I'm very grateful for Darren. And thank you.
Thank you.
Thank you.
I'm not sure.
The crazy paving part.